Next talk is by Dr. Anju Chandran, consultant oculoplastic surgeon at.
A very good afternoon to all of you. So I'll be presenting not a common case, but a very common presentation that can fool you. So this is a patient, 21-year-old male who came with complaints of painless drooping of the right upper lid. And he's been going around for about 2 years not knowing what the diagnosis is, and nobody has been able to help him, and because he was being treated as an allergic conjunctivitis. Otherwise, he's systemically normal, no other medical history that we should be concerned about. Now, looking closely, you can see these very serrated projections that can kind of mimic a papillae if you look closely. And he had this bilaterally on both the tarsal conjunctival regions, and not only the superior part, but if you look closely, also the inferior part had a slight involvement. Now that got me thinking, and since I hadn't seen an appearance like this before, I decided to consult with our cornea specialist, and he gave an idea that probably you're looking at a case of conjunctival amyloidosis. So now how do you prove this? So my first step was to go ahead with an incisional biopsy under local anesthesia, where I did like a gentle shave biopsy and the specimen was sent for histopathology, along with a complete blood workup with coagulation profile, as we do generally before any excision or incision procedures. And to a surprise, his APTT was prolonged in spite of repeating it twice. So, seeing that there was an abnormal APTT, I sent him to the hematologist and they did a detailed hematology workup, which included all the tests beginning from bleeding time onwards up to factor 8, 9, 11, 12 assay. And all these turned out to be normal, except that the lupus anticoagulant was elevated, which was not something that he had to be concerned about. I discussed at length with the hematologist. He said, we'll just keep him under follow up. Meanwhile, the histopathology report was ready and it was reported as a case of amyloidosis, as you can see closely on the magnified image where you see the amyloid fibrils. In this particular patient, since it was a clinching diagnosis on histopathology, we didn't go further with the other tests that we do usually for amyloidosis. Now, what we wanted to know is whether it was a localized one or a systemic amyloidosis. For this, the workup included investigations such as urine analysis, where you do a 24-hour urine protein, Bence-Jones protein, and beta-2 microglobulin, along with an ECG and echo to rule out involvement of the other structures, and a USG abdomen to rule out liver and renal involvement. Now it was a case of AL amyloidosis and it was localized. So next what? So surgical debulking was done for the patient as the ptosis was concerning him, along with cryotherapy to the edges. Currently he's under follow-up and he was desperately in need of treatment as he had to join for work at Hyderabad, and he's doing well now. His ptosis is improved. To my surprise, just about a week later, I had a patient with a similar looking presentation. And this time I was wiser. And when I everted, this was what I found. And you can see that pinkish to yellowish nodules that are there, which are almost pathognomonic of amyloidosis. So now coming to a brief discussion, it is a rare presentation. It, like we saw, it could be either localized or systemic. And the reason why it is diagnosed late is because it has a very insidious onset. It doesn't rapidly progress. And it has varied presentation, of which in the lids, it's usually ptosis, but you can have conjunctival involvement of the bulbar conjunctiva as well. And like I mentioned, tissue biopsy is the gold standard in periocular amyloidosis. And if you are to do an apple, you'll get a classic apple green birefringence there and a red green dichroism with Congo red stains, and when you look under the polarized light microscope. So it is imperative to have a systemic evaluation to rule out other sites of involvement. And surgical debulking with cryotherapy has been tried, and in very recalcitrant or very cases that do not respond to the primary management, you can always try additionally radiotherapy as well in localized amyloidosis. That's all. Thank you.
Thank you, Dr. Anju, for that insight on